Thank you very much. Thank you for the invitation. It's always delightful for me to be in Vancouver, even when it rains. I don't really mind the rain that much. I'm going to talk today about trauma-informed approaches in long-term care, but I'm going to provide a little bit of background, a little bit of data from work we've done, a little bit of connection into the new long-term care standards, and then focus a bit more on trauma-informed care and try and do that so that we have lots of time for discussion if we want. My program focuses on these areas, and today I'm going to be focusing more on the quality of work life for the care staff in long-term care homes, and also on quality of life for residents in these facilities, which goes hand in hand, as you well know, with quality of end of life. Our program is located in it's based in Alberta, but at different points in time, it's worked across the 4 Western provinces, and this fall we'll be launching our activity along with Alberta and Manitoba in the 4 Atlantic provinces, who have a really quite urgent need for data. They haven't had very good data systems there. The last British Columbia data I have is from about 2 weeks before the pandemic closed long-term care down. That was what we call wave 5, and I haven't got any data. BC hasn't participated since then. We're not a study. We're not a project. We're a collection of linked projects that occur over time. The core of what we do is a series of staff surveys, comprehensive surveys every 2 to 3 years. And at the same time, we collect the resident assessment data, the RI data, every 3 months from our participating organizations. And using that as a foundation, we do a series of other studies depending on what our investigators want to do, what the system wants us to do, and what's topical at the time. So today, when I present data, it's going to be a little bit from our breathing study toward the end, and a little bit from our COVID impact study, which was wave 6, the purple arrow on that picture, and comparing it where we have comparative data to wave 5. The Alberta government asked us in late 2020 if we could go in and do some assessment about the impact COVID was having on the workforce. So we started that work in early 21, and then Manitoba and Nova Scotia joined us a bit later. We did a whole series of things, from qualitative interviewing, modifying our survey, administering it, doing quality of life assessments with the residents, and collecting the RI data. And we did really extensive, more extensive than usual. We do quite a bit of feedback to the system. We do tailored feedback reports for each participating nursing home. And in Alberta, we have 35. And in total, before the pandemic, we had 91 homes in the program. So the data I'll present today, this is the amount of data we have. And if you're interested in how much BC data we have, it's combined in waves 3, 4, and 5. And BC was the largest contributor in those waves, because you have more homes than we do in Alberta. So you're a significant part of wave 5, which I'll be talking about, but only about the wave 5 Alberta data, because I want to compare it to the wave 6 Alberta data. So there's a direct comparison so that we can try and tease out what changes there were that we might think were related to COVID. So this isn't a really exciting slide, but it's an important one. Job satisfaction hasn't changed much over 15 years we've been collecting these data, but from wave 5 to wave 6, wave 5 is the blue line and wave 6 is the light green one, we saw quite a drop for a measure that's been as stable as it has in the unit managers. And that might not be that significant or clinically meaningful if it wasn't combined with a series of other things that happened to the managers when they gave us their reports on how they were doing. It's always been high. I think people don't stay in long-term care generally if the work doesn't have meaning to them and they aren't getting some satisfaction from their job. This is a new measure for us. We measured general anxiety. When we talked, we did about 100 qualitative interviews before we modified the survey, and we read the literature and we came up with 6 new measures that we added. And this was one of them. So this isn't actually a bad slide. We were concerned that it might be worse than this. This doesn't measure event-specific anxiety. It measures general anxiety. So how anxious you are at a person is wrapped into this quite significantly. But a relatively small proportion of staff in all levels, it goes care aides, nurses, managers, and allies down the left in terms of who's represented in those bars. Relatively small proportions have severe anxiety. It's not trivial, but it is fairly small. And we were concerned that that might be much higher. What's important about this measure, which was new for us, is if when we go out and ask these questions again, has it gotten worse? Has it gotten better? Or has it stayed about the same? And what we hope we see for all of these measures is that there's an improvement as the COVID conditions lift. I don't know if that hypothesis is going to be proved out because you're also in the middle of, I think, what's legitimate to call a global workforce emergency in the health settings. And certainly long-term care has some particular difficulties that it's dealing with in terms of adequate supply of staff. This was another new measure for us. And here you see compassion fatigue it's related to the whole set of things that you would look at around burnout and moral injury and one's ability to continue caring and how much fatigue you're experiencing because you're working under difficult situations. About a third of all levels of staff report high levels of compassion fatigue. And I don't know what it was pre-COVID and I couldn't find anybody who'd measure it in these populations. And about a third have low compassion fatigue and about a third are in the middle. So that's quite significant. A third of all levels of staff are experiencing compassion fatigue. What will be more significant is if that doesn't begin to ease when we go in, it'll be 2 years later when we go in. Certainly the interviews that we have with staff support that they're under a fair bit of duress still. Many people on our team get very excited about this one, and it's an important measure, but it's really important to remember it's a screening tool. It's not diagnostic. So if you scored in the red in a physician's office, you probably get referred for further mental health support. But so a third, 25 to 30% of people are screening positive for PTSD. Even at the screening level, to get yourself into that red zone, you're having to report quite a significant number of symptoms that are intrusive and difficult. Intrusive nightmares, angry outbursts, high levels of irritability, inability to focus, those sorts of things. If you're in the red zone, you're feeling the effects of that in your work and in your personal life. If it persists and becomes entrenched, it can be very detrimental to your health. So PTSD gets a lot of talk now. It's a really serious disorder, but it can be addressed. It's not terminal. Although there are people in long-term care and across the world who've lived their entire lives with fairly severe PTSD, and it can be quite crippling. So we'll be watching this one really carefully. I was actually worried when I saw it, but also quite relieved that it wasn't worse, because this is pretty consistent with what other studies are reporting across the world at the height of COVID. So it's reasonable to assume that this would begin to ease, and probably has eased. If it hasn't, that's a much more concerning event. So why did we do all this? We believe that if you can't measure something, you can't manage it well. And one of the problems in long-term care across the country has been a lack of data on the workforce. It's really hard to even count the number of people who work in long-term care, especially at the care aide or PSW level. And if you don't know that your workforce is struggling, then it's easy not to put specific programs in to help them and to create the conditions that would be more helpful to them. I was actually more concerned about this measure, compassion satisfaction, because, for example, 60% of managers reported very low levels of this. I don't know, but my worry would be that it's an earlier indicator, that it moves earlier than some of the other ones. if that's the case, some of the ones that I've just shown you may worsen. We'll see. We just don't know yet. But those are actually quite extraordinarily significant levels of staff at all levels reporting low compassion satisfaction. It's very difficult to go on in your job indefinitely if you can't get satisfaction, and if you are continually exposed to things that create cognitive dissonance and conflict and lead eventually to moral injury, which we've heard a lot about during COVID. I mean, it's not been easy for staff working in long-term care to see people essentially put under conditions of solitary confinement for periods of time. And we've all begun to see the reports of how that's played out with the resident population. And it's gut-wrenching to not let families come and be with their loved ones who are dying. And it's horrible to be scared. Remember, we can all remember back to the early days of the pandemic when nobody knew how it was spread and people were scared they were going to get it, and they were scared they were going to take it home to their families. And people went to extreme lengths to try and protect their families, but still continued to work. So it's not surprising they took some hits. This was about 18 months into the pandemic. So Omicron was alive and well and raging around the world at the time we took these data. This one I have more confidence about how serious it is because we've been measuring burnout using the Maslach burnout inventory for 17 years, and we know how it performs. So any movement on this is serious because this thing is just as stable as a rock. The scores have not changed over time. That's in some ways the good news, but in other ways it's not such good news because if you look at how it goes is the top two sets of bars are cynicism, and the bottom two are emotional exhaustion. Emotional exhaustion is a little more sensitive to changes that you're exposed to, so we pay more attention to that one. But these two together, combined with low levels of professional satisfaction, create burnout risk. And this has been used all over the world, so we have a lot of confidence in it. But look at the levels. And so if you look at the top three bars and then the next three, the top three are COVID-19. That would have been in the fall of 2021. And the bottom three are approximately in the fall of 2019. So 2 years apart. Even in 2019, almost half of carries were reporting cynicism and emotional exhaustion scores that placed them at very high risk for burnout. Nurses and managers similarly, not quite as high. So this was high before COVID ever came along, and it's hard to move this. And then if you look at what happened in wave 6, which is the COVID wave here, wave 5 is the pre-COVID. If I put my glasses on, I could probably see that a whole lot better. Imagine that interesting phenomenon. When you put your glasses on, you can see. The top one is COVID-19, and the bottom one in each set is wave 5, which is pre-COVID. So pre-COVID on the bottom, post-COVID sort of on the top, mid-COVID really. If you look at what happened to the managers in particular, if you look at emotional exhaustion, that's a twofold increase in people scoring at high risk for burnout. The care aides and the nurses don't shift as much from pre to post-COVID. I'm going to say pre to post. It's pre to mid-COVID, really. But the managers took a significant hit here and on a number of other things that we measured. So the news there is that burnout risk remains very high for all staff, but it's increased twofold for managers. So we went to the government midway through this data collection and did a kind of an emergency brief and said, we're seeing things in the manager group that are so troubling that we need to report these to you before we have all the data in. And then when we talked to them, I've never given webinars. And I said to one of my staff, I said, why do managers turn their cameras off all the time? It's hard to see what how they're responding. And she said, well, they're doing that because they're crying, Carole. I said, oh. And part of that crying, I think, was just seeing what they were feeling expressed in data. They've really struggled. And then this is always been a good news slide. This is the third measure in burnout. And you want lots of green because it's professional efficacy. It's the sense that your work has meaning and value and you get a lot from it. We think that's probably acted as a buffer against emotional exhaustion and cynicism. And it hasn't moved that much, but it moved, and it especially dropped in the managers more than we would like to have seen. So it moved a bit for everybody, but not a lot. But the fact that it moved at all with these burnout measures I find them quite troubling because they just don't move, which tells me that there's a fairly chronic state of duress and difficulty with the work involved in long-term care. And COVID, not surprisingly, actually moved it. So what's that got to do with trauma-informed care and the new National Long-Term Care Standard? Well, those are the data that support the kinds of effects that people have had from COVID. And I haven't shown you resident data. The resident data that we have hasn't moved as much as, and it's difficult to look at it home by home. You need to look at it in the aggregate. We're starting to see reports of excess mortality, which is not surprising, of increased dependency and lower mobility. And there was some increased use of antipsychotics during COVID. So things like that did change. I know that Samir talked about the long-term care standard yesterday, so I'm not going to talk about it a lot, except as it pertains to trauma-informed care. There's 6 sections in this standard. There's another parallel standard I'm sure you talked about that has to do with the physical plant and IPAC and HVAC systems and the size of homes and the size of rooms. That was a brand new standard. This standard was a major overhaul. This was done over 2 years with a panel of 32 people and about 18,000 sets of input from Canadians across the country. What I want to point out is that 2 of the main criteria in it talk about a standard related to a trauma-informed approach to care. In the first section, the governing body ensures the home has a trauma-informed approach to care. And then in the second section, the home leaders implement a trauma-informed approach to care. It's also mentioned 51 times in the standard. So it's a big part of the standard. It's not unrelated to resident-centered care and person-centered care and relational care and to all the things that Eden homes and greenhouses and green farms and dementia villages try to do. But it does have some unique features. And it's now, thanks to COVID, I suppose one could say, more respectable and less stigmatized to talk about trauma, but it's still not entirely unstigmatized. Trauma is any major event that creates a major stressor where you feel overwhelmed or unsafe and often aren't able to get relief from it. And the problem with trauma was a lot of problems with it. Vanderkolk calls it the #1 public health concern in the United States. Gabor Mate argues that all addiction and substance use has trauma at its root. We know that 5 to 10% of the general population experiences PTSD, and that's just PTSD, which is smaller than trauma writ large. And we know that COVID created conditions of traumatic stress for everybody. And that's what I think we're seeing in the PTSD scores. So trauma-informed care, but just before I say what the 5 principles are, I don't know if you know about the ACEs studies, but the adverse childhood event studies were done some time ago, and it's a small scale. There's a test that tells you what your score is on the ACEs scale. And a score of 6 or more will predict a 20-year shorter lifespan. So trauma has a really profound effect on our physical health, not just our mental health. Untreated and unmanaged, it sets off a cascade of things in the brain and the nervous system that create, it's kind of like putting your foot on the accelerator when you have to fight or flight and you can't get your foot off, it stays stuck. And so it bathes you in sometimes a lifelong bath of cortisone, and you get inflammation, and it leads to a whole set of metabolic syndromes and chronic diseases and diabetes and pain and cognitive impairments and on and on. So it has serious health consequences. We're most familiar with things like combat veterans, Holocaust survivors, first responders who've experienced horrific events, Lots of worry about it after 9/11, but many, many people have traumatic events. And one of the challenges in long-term care is that a lot of people manage their symptoms and their histories quite well using their prefrontal cortex and their executive functions. And they have good relationships and they have jobs and they develop a sense of mastery and they get on quite well in life. But when dementia starts to thin your cortex and take some of your structures apart and take away your executive functions, it can become very difficult for some people for those symptoms not to flare up again. Move to a nursing home can be traumatizing. And we do lots of things in all kinds of health settings that are re-traumatizing. So the goal of trauma-informed care is to not re-traumatize people. It has principles of safety, trustworthiness, choice, collaboration, and empowerment. And it's easy to write these into mission statements, but if all we do is write them in mission statements, it's not enough. We have to operationalize them and make them happen. And it applies equally to the staff, because the staff, everything that's in a nursing home is everybody's lives all come to rest. If you had substance abuse, you're bringing it with the home. If you had psychiatric disorders, et cetera, et cetera, et cetera. And the staff, as you know, are a complex group, especially in the care aid staff, but also in the nursing staff, high proportions of them from other countries. They're paid poorly relative to other workers in other settings. They have lower levels of education and they get the least amount of continuing education. So they're in a difficult, vulnerable position looking after really complex and vulnerable residents. So this is just another way to say similar things. A good trauma-informed approach attends also to cultural and historical and intergenerational issues, to race and gender. It extends person-centered care and advocates for positive environments that integrate trauma knowledge and extend the person care model to residents with these histories. And it uses neurobiologically informed interventions and supports workers. And especially now, it's relevant. It's been a requirement in the United States since 2019, although the pandemic slowed down their work. It's very well embedded in the Australian processes and standards and in some European states. Canada's been way behind the 8 ball on this in long-term care. There are some acute care settings, and I know some of you in the audience are working on it in long-term care, but it hasn't been implemented systematically across the country. There are a lot of resources. That's the good news. And this is my favorite, but there's a lot of good ones. This is from the School of Social Work at Buffalo, the University of Buffalo. And I like it because it's clear, it's laid out nicely, it's got nice pictures, and it talks about how complex, but how doable it is. You have to start with change at the top, but you also have to work from the bottom up. People need to understand how trauma affects people, and they need to understand that some BPSDs, or responsive behaviors of dementia, especially in those residents that are quite refractory to intervention, are probably PTSD. The good news is some of the trauma-informed interventions that are based in neurobiological knowledge also work for regular responsive behaviors of dementia. There's overlap. It's like a Venn diagram. Some of the changes organically in trauma are similar to some of the changes that happen with dementia. A lot of places like Baycrest has a lot of Holocaust survivors. And a lot of what it's about is managing the environment. So for them, the showers are a very big deal in terms of how they manage residents in the showers. For a home with a large proportion of Indigenous residents who've been in residential schools, porridge is often not fed at breakfast because it's a big trigger. A lot of residents from those sorts of environments have hoarding issues because they were starved so at such extreme levels. Soldiers are classic. I mean, they'll even tell you, well, you have to be careful about me because, if a loud noise goes off, you find me under the bed because it just sets me off. That's often the way they'll talk about it because of the gunfire. If you've had near drowning experiences, bathing may be an issue. If you've been sexually assaulted, a male caregiver or pericare, those sorts of things can really set people off. If you've been a firefighter, you have different. So it's about knowing the resident, knowing their history, which is very consistent with person-centered care. and about creating an environment that tries to mitigate those triggers and understands when somebody's set off. Because all behavior has some meaning, it's just that we often can't figure it out. And then thinking, what are neurobiologically informed strategies? Well, they're just strategies that work on, for example, your nervous system, which gets really dysregulated, or works hormonally. Like if you can do something to get oxytocin to be released, that's going to help the resident a whole lot. That's a really lovely drug to have released. So that's where we think some intentional pet therapies work, is that they cause the release of oxytocin. They also work in some other ways. I don't mean pet visitation, which is important, but it's not focused therapy. It's usually not long enough to create some of the effects. And the sympathetic nervous system, what happens in trauma often historically is that your sympathetic fight or flight or freeze system gets set off. So your little amygdala sees something and thinks, oh my God, that's like when I was in the war and that happened, and it pulls the fire alarm and the whole system goes into overdrive. So if you can upregulate the calming part of the system, the parasympathetic system, music, co-regulation with an animal, quiet sometimes, connection with people they're familiar with. There's all sorts of things that you can do. Weighted blankets work for some people. If you can upregulate that, you can put the system back in balance. So it's being intentional about the kind of things that we do. And that's just basically what I think I want to just mention screening and history taking. We interviewed a fair number of carries and we said, what would help you look after these folks? And they said, well, if somebody could just please take a history when they're admitted, then we wouldn't have to spend 6 months or a year figuring out why they went so crazy when, for example, we lowered them into a bathtub. So you won't know everything from a history, but it's possible to get lots of history from some residents and from families. And we used to do this in Alberta, but we stopped it. So I think we're going to re-implement making that part of the history. Then I'll just put a couple of slides for a project that's neurobiologically informed. It's intended to work on your parasympathetic nervous system. We were asked in the middle, when we said, well, look what's happening to the staff, the government said, well, can you do anything? And so we scrambled around and were able to tap into some of the HEC long-term care plus funding. And we set up a project I call the Breathing Project. So an 8-week study, pre-post, very simple. Some introduction and basic education, some measuring pre and post, then 8 weeks of coherent breathing, which is not, there's lots of kinds of ways to breathe. You see breathing, and well, we have to breathe kind of to survive, but yoga has breathing, Pilates has breathing, mindfulness has breathing. There's lots of things where we do breathing. This is just a particular type of breathing. And the key to it is inhaling and exhaling evenly to whatever count works for you. And it probably adjusts the parasympathetic nervous system and slows the heart rate and digestion, etc. We asked them to start with 1 or 2 minutes a day and work up to by a minute per day, or at whatever rate they could, until they were at 8 or 10 minutes, 7 days a week. So we considered 5 days a week successful. And these are what the formal statistical results look like, if you're interested in that sort of thing. Everything improved that we measured over 8 weeks, except compassion satisfaction. There was a small sample of about 250. So the significance is unlikely to be because we had a big sample size. Other things may have caused this improvement, the most likely being that COVID was lifting, but it was such a short intervention that we think most of it was due to the breathing. I was particularly keen that we get insomnia in because it's such a major health indicator. And we measured anxiety and depression using a different scale here. So we were excited about this, but I was more excited when we did interviews and focus groups during and after, because we were worried we were going to have a high attrition rate and we wanted to know why that was happening. So these are some of the things that staff said. These are mostly carries, but nurses also, and a group of about 30 managers. So the Alzheimer's residents can't communicate well, but when you're calm, they're calm. So they figured out all by themselves, if they regulate their nervous systems, it helps regulate the residents. I didn't expect to have such a good improvement just from breathing. In fact, your stress levels will go down and you can focus more on what you need to do. And then some of them got very creative. During work, before work, and after work, after I got home, before I went to bed, after my shift, anything at work. If it was anything that happened or anything that with some of the residents, I used the breathing just to back up and take 5 minutes. So this usually started to happen around 5 weeks. So it looks like it takes about 5 weeks to internalize it and get the hang of it. Here's a nurse who thought it helped her perform well on her licensure exams, and she passed, so she gave the breathing study credit, so I was happy to take it. This is from a home where the manager just went a little crazy with it, which in a very positive way. Anytime they have something, an altercation or a code or an aggressive outbreak, they have a debrief, and to get everybody's levels down, they start with a breathing huddle, which I thought was rather creative. And they just incorporate it into the way they do business. And then an LPN says, we carry so much stress, and if you can just use the breathing, you can bring it down. So I've been sharing it with people all the time. A lot of them talked about using it with their kids. So we have been doing work on trauma-informed care since about 2 years before the pandemic. And this was and I'm an applied health services researcher with a nursing background. I'm not a neurologist or a geriatrician or a psychiatrist. And so we put a psychiatrist and a neurologist, a geriatrician, and a trauma psychiatrist on the team to make sure that we were with the program and weren't just making stuff up or misinterpreting the literature. And this is a call for policy and research action in Journal of the American Medical Directors Association. And since one of my doctoral students has published some data about care aides working with these folks, and she's currently doing an extensive group of interviews. So this is pretty high level, and I wanted to keep it that way, but also try and talk about some of the details and some of what's happening to the staff that makes it even more important we do these things. So thank you so much. And if you have any time for questions, I'm happy to take them.